In many ways, it's the most prescribed drug in the hospital, oxygen, and it requires a fair amount of understanding and knowledge to prescribe and treat a patient with oxygen and to understand the mechanisms of hypoxemia that we've already covered and the delivery systems for this particular agent. In this, the first of two tutorials, I'm going to look at variable and then fixed performance oxygen delivery devices, starting with nasal cannulae and finishing with non-rebreather face masks. Tutorial 15. Hypoxic respiratory failure, Part 4. Oxygen therapy, Part 1. Previously, we discussed the mechanisms of hypoxemia, and I discussed the three different causes of atelectasis: compression atelectasis, obstructive atelectasis, and absorption atelectasis. Then we went on to discuss ventilation perfusion mismatch and shunt, and how these are the mechanisms behind hypoxemia. At the end of that tutorial, I introduced oxygen therapy and discussed hyperoxia. This time I will discuss the basics of oxygen therapy, particularly discussing peak flow and why it is really important. I will then go on to talk about nasal cannulae, simple face masks, and Venturi devices. And then finally, we'll look at non-rebreather masks. Now, you've already been in the medical assessment unit and you have seen Trish and Jesse. Remember, Trish was admitted to hospital with community-acquired pneumonia and was treated with 30% oxygen, to which he initially responded well. Jesse was admitted with a COPD flare. He was treated with 50% oxygen, and that was problematic. His PaO2 was too high and he started to develop CO2 narcosis. Part of what I'm going to talk about in this tutorial is how we actually go about delivering 30% and 50% oxygen to these patients. We will also discuss another scenario. You're in the recovery room and you encounter Magella, and we will encounter Magella a few times. She's 54 years old and has a body mass index of 54, so she has obesity. She's post-operative and she had a cholecystectomy, and intraoperatively she got 10 milligrams of morphine, has been back in the recovery room for 30 minutes, very sleepy. Came back on 40% oxygen, and that hasn't been weaned at all, and she has slow, shallow breathing. She currently has a saturation of 94%, and as I mentioned, the recovery room nurse is struggling here because she's wondering why the FiO2 won't go down. So let's start this discussion looking at the fundamentals of oxygen therapy. When we talk about hypoxemia and respiratory distress, we are referring to one of three manifestations. The first is rapid shallow breathing, and that generally results from poor lung compliance. And by that I mean the lungs inflate with a certain force, and if the force that is required to inflate those lungs increases, the compliance of the lungs has reduced or the elastance has increased. On positive pressure ventilation, we measure this in mils per centimeter of water. The second manifestation is rapid deep breathing consequent of activation of the hypoxic respiratory drive. In this situation, the patient is hypoxemic due to right to left intrapulmonary intracardiac shunt, but the lungs remain relatively compliant and the patient takes a lot of big deep breaths. And we saw a lot of this during the COVID-19 pandemic. The third manifestation is slow shallow breathing, and this results from the causes that are of respiratory depression. These are central and peripheral causes that I discussed in a previous tutorial. The PaCO2 typically rises and displaces oxygen within the alveoli. Now, each of these three presentations, rapid shallow, rapid deep, and slow shallow, are indications for oxygen therapy. These days, oxygen therapy is typically titrated. That is, the inspired oxygen tension is carefully tailored to a specific oxyhemoglobin saturation or partial pressure of oxygen in arterial blood. But there is a second component to oxygen therapy, and that is gas flow. This gas flow is typically adjusted to match patients' flow demands, particularly to ensure that they get the correct inspired oxygen tension and to reduce respiratory distress. And from the flow discussion, we need to talk about what defines the need for gas flow at a particular level. And this is the problem of peak flow. Now, this is a flow meter, and you've all seen these. And when you turn the flow meter on, oxygen comes out. And what's coming out of the flow meter is 100% or pure oxygen. When we're treating most patients with oxygen, we connect some tubing to the flow meter like this, and that tubing connects to an apparatus that is applied to the face, covering the nose or the mouth or the nose alone. And to figure out how much oxygen you're giving, you need to look at the device itself, the flow deliverer, and how much air is entrained. And what I mean by air entrainment is the blending of oxygen and air, usually ambient air, in the room that the patient is in to come up with a precise inspired oxygen tension. You cannot understand oxygen therapy unless you understand peak inspiratory flow. When you take a breath, the average tidal volume is somewhere between 300 and 550 mils, depending on your size. But the tidal volume may increase to 700 or 800 mils on occasion. Most of the time, we breathe through our noses. And when we take a breath, the initial flow is high, and then it decelerates until the flow ends. The point of maximum flow is the peak inspiratory flow. And this is usually more than 30 liters per second. It can rise to 60, 70, or even 100 liters per second in patients who have severe respiratory distress. To apply oxygen to a patient, you need to figure out what the peak inspiratory flow is. The rule of thumb is that it's 3 to 4 times the minute ventilation. Now, let's apply supplemental oxygen through a face mask. Oxygen is delivered via the tubing to the face mask. Note that there is a continuous flow of oxygen into the mask and into the nasopharynx, the concentration of which should be predictable. Note also that there is no inspiratory or expiratory flow. When the patient initiates a breath, oxygen-enriched air enters the major airways, and you can see the sinusoidal flow pattern on the cartoon. The peak flow can be measured from the waveform. The goal of oxygen therapy is to ensure that the inspired oxygen tension is unchanged during peak inspiratory flow. So let's summarize that. Oxygen flows along open airways throughout the respiratory cycle, and the anatomic dead space acts as a reservoir, and that reservoir includes the nasopharynx. If one is using targeted oxygen therapy, then when the patient inspires, the FiO2, the inspired oxygen fraction during peak flow, must match the FiO2 during the remainder of the respiratory cycle. So, how do we solve the peak flow problem? There are 3 types of oxygen delivery systems: low flow systems, moderate flow systems, and high flow systems. Low flow systems typically use the pharynx and perhaps a face mask as a reservoir for gas. When the patient inhales, flow is drawn from the fresh gas source and entrained from reservoir gas in the mask and the pharynx and blended with air from the room. Moderate flow systems use reservoir bags that fill during expiration. When the patient inspires, they draw fresh gas from the source and stored gas from the reservoir bag. And that bag does not fill with expiratory gases, so it's known as a non-rebreather bag. Finally, in high flow systems, gas flow is sufficiently high to match the patient's peak inspiratory flow demand so that no reservoir or air entrainment is necessary. So these are high flow oxygen devices. That will be the major topic of the next tutorial. How do we deliver oxygen therapy? Well, we can use low to medium flow systems, and these are either variable performance devices or fixed performance devices. With regard to variable performance devices, when we use simple face masks or the so-called Hudson masks or nasal cannulae, that's what we're doing. And these are ideal devices for managing mild hypoxemia. The performance is variable, and what's meant by that is that, yeah, you might get the FiO2 you think you're getting, but under certain circumstances, you won't. In terms of fixed performance devices, these are airway devices where you administer a certain flow of oxygen and you're pretty sure that the patient is going to be getting a specific inspired oxygen tension. And these are usually Venturi devices, and we'll talk about these extensively later on in this tutorial. There are other things such as partial rebreather face masks and non-rebreather face masks, and all of these can be used for managing the patient with moderate hypoxemia up to an inspired oxygen tension of about 60%. Beyond that point, it's really hard to be sure that you're giving the patient adequate flow, and we will talk about that later on. And finally, there are high flow systems. That's what's in all non-invasive ventilators. It's what's in all invasive ventilators. But where you will see a lot of these out on the wards these days are flow generated devices to deliver high flow through nasal cannulae. And the next tutorial will focus on high flow systems. But let's start with nasal cannulae. Nasal cannulae are made up of a pair of 1 centimeter prongs that point upwards into the nostrils. The tubing is positioned either circling the ears or wrapped around the head, as long as they're fixed in position, and fresh gas is delivered via a flow meter on the wall. That fresh gas is 100% oxygen, so what comes out of the nasal cannula is always 100% oxygen. What it is adjusted is that flow of oxygen. The gas, because it's coming straight out of the wall, is not humidified, and it is believed that moderate levels of non-humidified gas into the nose are well tolerated because the patient is able to humidify that gas themselves. At higher flow levels, it becomes quite irritating for the patient. So generally, we use moderate levels of flow, up to 6, perhaps 8 liters of flow. And beyond that, we kind of think about using something else. Let us administer supplemental oxygen through nasal cannulae. Oxygen is delivered via the tubing to the nasal specs, and then the nasopharynx acts as a reservoir. Note that we have continuous flow of oxygen, and based on the flow of, say, 2 to 6 liters, we believe that the FiO2 is predictable. Again, there is no current inspiratory or expiratory flow, so this is the steady state situation. Now, when the patient initiates a breath and oxygen-enriched air enters the airways, we have a combination of 3 things. We have the fresh gas flow, we have the air that is coming from the nasopharynx that is blended in with the fresh gas flow, and we have air being entrained from the space outside. So this is sometimes called room air. 3 different things: supplemental oxygen in the nasopharynx, and entrained air. And that all blends together. So by the time that this gas enters the trachea and bronchi, there should be a very predictable inspired oxygen tension. Now again, you can see the sinusoidal flow pattern on the cartoon, and the peak flow can be measured. The goal of oxygen therapy is to ensure that the inspired oxygen tension is unchanged during peak inspiratory flow. However, if the oxygen flow rate or reservoir is lower than what is demanded during peak flow, the FiO2 is lower than expected. And that is why the performance of these devices is variable and why they may be inappropriate for treating patients with respiratory distress. So far in this course, we haven't mentioned the Bernoulli effect, which is really a jet effect with gases often labeled somewhat inaccurately or colloquially as Venturi effect. And that's how I'm going to describe this process going forward. We're going to just call it a Venturi, although lots and lots of discussion in the literature about exactly what this is. When gases or fluids pass through a tube, there is a forward propelling kinetic energy, and then there's also potential energy being applied to the sides of the tubing. All energy levels must be equal. If the tubing narrows, then the forward flow velocity increases. Increasing kinetic energy, and as a result, the pressure on the sidewalls, the potential energy, drops. Why is this important? Let's add some tubing to this picture that contains liquid or gas, and that tubing is going to be at the level of the constriction. Once the flowing gas or liquid enters the constriction, a negative pressure is generated on the side tubes, and the material in those tubes is sucked into the main system and mixed. This happens when you breathe through your mouth. The aperture narrows in the pharynx and trachea, and this sucks gas from the nasopharynx into the main airways and through the nostrils. So while wearing nasal cannulae, it's perfectly fine to breathe through the mouth, because what happens is gas flows into the mouth, and by the Venturi-Bernoulli effect, it is in the nasal pharyngeal reservoir is injected into that gas flow as it goes down into the trachea. So the operation of nasal cannulae is two prongs that go 1 centimeter into each nostril. Nasopharynx is a reservoir for oxygenation, although nasal breathing is not necessary. And the mouth breathing causes inspiratory flow, and the Venturi-Bernoulli effect goes on in the posterior nasopharynx, and that entrains oxygen from the nose. The inspired oxygen tension depends on the oxygen flow rate, the volume of the nasopharynx, the respiratory rate, and the tidal volume. Well, how much oxygen do you give for flow? This is a good rule of thumb. If you start with 20%, I know normally the air is 21%, but this is the easy way of remembering this as a rule of thumb. For nasal cannulae, above 20%, every 1 litre of flow adds 4%. So 1 litre gives you 24%, 2 litres gives you 28%, 3 litres 32%, 4 litres 36%, 5 litres 40%, and so on and so forth. And this, it's a really easy way of remembering this. Remember that, of course, once you get above 4 or 5 litres, you're getting pretty high flow going in there, and it can be quite irritating for the patient. So usually we don't give more than 4 or 5 litres of flow, but honestly, you can give 10 or 15 litres if you really want to without too much trouble, and it will give a fairly high inspired oxygen tension. So for very short periods of time, yes, you can absolutely give much, much, much higher levels of flow. The big advantages of nasal cannulae is that they are comfortable, the patient can talk, the patient can eat. The patient feels normal with oxygen flowing into their nostrils. The disadvantages are the dry gas that's irritating to the nares, and it will limit the amount of flow that you can give. The FiO2 can be quite unpredictable, particularly if the patient's in respiratory distress. And realistically, if the tidal volumes are varying a lot, or the respiratory rate is going up and down, it's really hard to know if the patient is getting the FiO2 that you think that you're giving them. Due to a series of sentinel events in the early 2000s, these days it is considered standard of care to measure end-tidal CO2 in patients who are sedated, and this can be achieved with modified nasal cannulae. These are a couple of examples. You can see here these are gas sampling ports that are located just below the specs, and they measure carbon dioxide as it's exhaled from the mouth. So the device just kind of sits on top of the mouth. Now, although these devices generate a capnometry number, it just tells us that the patient is breathing in an unobstructed or partially obstructed manner. At least they are moving air in and out of their mouths. The number doesn't actually reflect the true end-tidal CO2 because of gas mixture and leakage, but it's really reassuring to actually see a number, and particularly if you're working in the operating room with someone who's sedated, to see a nice waveform. Let's move on to face masks. These come in all kinds of shapes and sizes, and I'm going to start with simple masks. These are sometimes known as Hudson masks. This is a standard face mask. Note that the mask attaches directly to the oxygen tubing and then onto the flow meter. So what's entering the mask itself at that junction is 100% oxygen, just like nasal cannulae. Note also that there are exhalation vents on the side of the mask. That allows gas to pass out of the mask with very little resistance during exhalation. However, be aware that there needs to be sufficient flow through the mask to ensure that the patient doesn't rebreathe the gas that they have just exhaled. Now let's apply supplemental oxygen through a simple face mask. Oxygen is delivered via the tubing to the mask, and the nasopharynx again acts as a reservoir, as does the mask itself. Note that there is again a continuous flow of oxygen into the mouth and nasopharynx based on the flow of 5 to 8 liters, and we believe with that flow the FiO2 is predictable. Again, there is no inspiratory or expiratory flow at this point in time. When the patient initiates a breath and oxygen-enriched air enters the major airways, it does so having derived air from the fresh gas flow, from the mask, from the nasopharynx, and from the air outside. And this all gets blended in. And the purpose of all of the dialing up a specific flow is to ensure that everything gets blended into the right mixture so that when the gas goes into the trachea and down the bronchi and down to the alveoli, the patient gets the FiO2 that you're looking for. Again, you can see the sinusoidal peak flow pattern, and the FiO2, we hope at that peak flow time, is exactly the same as it was before the breath even started. And again, if the patient takes faster or deeper breaths than expected, it is possible that during peak inspiratory flow, the FiO2 will drop, and this will lead to a lower partial pressure of oxygen in the blood. These are variable performance devices. Now, something that you must be aware of when using face masks is their volume. The volume on the inside of this mask is 200 mils. I know because I measured it. That obviously drops when the mask fits snugly to the face. I estimate that the true value of the volume in this mask is about 150 mils. That is not an insignificant volume. It represents both a reservoir for oxygen and additional anatomical dead space. And that's why the base flow that you use with face masks needs to be a lot higher than with nasal cannulae. With nasal cannulae, you can start with 1 liter, but with face masks, you really have to start with 5 liters. So let's look at the rule of thumb for face masks. Face masks are flow dependent. For every additional 1 liter of flow above 5 liters, this adds 5% above 30. 5 liters gives you 30% oxygen. Every 1 liter of flow adds 5%. So, for example, if you give the patient 8 liters, the FiO2 with these masks should be 45%. This is absolutely true. I've measured this myself with normal breathing, but it is problematic beyond that. So here's just a simple way of looking at this. 5 liters, 30%, 6, 35, 7, 40, 8 liters, 45%, 9 liters, 50%, 10 liters, 55%. The major advantage of simple masks is that they are reasonably comfortable, and some people don't like having prongs going up their noses. You do get some humidification of inspired gases just from the heat of the body around that mask. You get a slightly higher FiO2 than with nasal cannulae at higher flows, because you don't have that drying effect, and the mask can be relatively easily weaned down to 30%, but then at 30%, as I've mentioned before, at 5 liters, you run into trouble with rebreathing. And that is the big problem here, and it's always a possibility in a patient who's hypoventilating. The FiO2 is unpredictable though when the respiratory rate and tidal volume go up and down. Let us look at some data on how these devices perform. These data come from a paper in the journal Anesthesia from 2007, and using a model, so this isn't humans, it's quite an elegant model, the authors were able to compute the impact of increasing respiratory rates and tidal volume on the effective inspired oxygen concentration, and that's what you see here on the y-axis. What we have on the left is nasal cannulae, and on the right we have simple face mask. You can see we have different flows marked out, and we're going to look at different respiratory rates, 10, 20 and 30 breaths per minute with 300 ml tidal volumes. The FiO2 is 40, 60, 80 and 100%. Ignore the surprisingly high starting FiO2 and see what happens when the respiratory rate increases for 2 litres, 6 litres, 10 litres and 15 litres of flow. That's for nasal cannulae, and we can do the same thing with the face masks, 2 litres, 6 litres, 10 litres and 15 litres of flow. And you can see that there's a fairly dramatic drop off in effective delivered FiO2, albeit to fairly respectable levels at higher respiratory rates. Now in this picture, we have increased the tidal volume to 500 mils. And let's see what happens. Starting with 15, 10, 6 and 2 litres, you can see there's a pretty dramatic fall off in the FiO2 with nasal cannulae. But if you look at the face mask, it's significantly worse. Look how spectacular the fall off in the inspired oxygen tension is, where the respiratory rate goes up with a much higher tidal volume. So the face mask really struggles. The nasal cannula do okay. They're not great with the bigger tidal volumes and the faster respiratory rate, but the drop off is dramatic, but not a whole lot worse than it was with 300 mils. With face masks, big difference. So nasal cannulae and simple face masks perform adequately at slow respiratory rates and modest tidal volumes, and I think that nasal cannulae perform marginally better than simple face masks really across the board. And bear in mind, you can use much lower flow rates with nasal cannulae, but the effective inhaled oxygen concentration really drops dramatically with an increase in respiratory rate and an increase in tidal volume, and that is a lot worse with face masks. Let's return to Magella in the recovery room. Now you'll recall Magella had a cholecystectomy and had a fairly decent dose of morphine. She's been back in recovery for 30 minutes and is stuck on 40% oxygen with slow, shallow breathing and a saturation of 94%, and they're not able to wean the oxygen. What I have here is a curve that demonstrates the relationship between alveolar ventilation and the rise in the CO2 that results. So as the alveolar ventilation drops, and we saw this in the tutorial on ventilation, the partial pressure of CO2 in blood goes up. Because the alveolar CO2 content rises, oxygen is displaced and a higher FiO2 is required to maintain an adequate alveolar to arterial oxygen gradient. Let me show you the required FiO2 at each level of alveolar ventilation required to achieve this. So here we are, 21, 25, 30, etc. Now what is a little bit scary here is that one can administer 30% oxygen to this patient and achieve a respectable saturation of 95% despite a 1.5 litre alveolar ventilation. That 1.5 litre alveolar ventilation is associated with a partial pressure of CO2 of 100 millimeters of mercury, or approximately 13 kilopascals, and that will result in a profound respiratory acidosis. Obviously, even higher levels of oxygen will cover up profound hypoventilation even more. So this is potentially a really dangerous situation where a patient could literally fall off a cliff. And I believe one of the dangers of only using pulse oximetry to monitor profoundly sedated, oxygen-dependent patients. So I think Magella in the recovery room should have nasal cannulae with that little end tidal CO2 monitor to monitor her ventilation while she's receiving that amount of oxygen, or an equivalent face mask with the CO2 device attached. So when can you use a simple face mask or nasal cannula? Well, certainly in a hypoventilating patient, certainly there isn't a problem because the rate and depth of their respiration is quite slow and low. And really, the post-anesthesia care units, the recovery rooms, this is the ideal location for these devices. But remember, you have to be very, very careful with them. Certainly, they are very useful for mild to moderate hypoxemia because they're available. There's only one thing to change, and that's the oxygen flow. So it's very simple to use for inexperienced users on the ward. There's very little fiddling going on. You can dial the flow meter up and down in response to the oxyhemoglobin saturation. And of course, nasal cannulae are just ideal for long-term oxygen therapy. That completes the discussion on variable performance devices. Let's move on to fixed performance devices, the first of which are Venturis. What makes these masks different to simple face masks that we've already discussed are the conical shaped devices that are attached between the fresh gas flow tubing and the face mask, and these are known as Venturis. There are a variety of different versions of these that you will find in your equipment store in your hospital. These are the most common versions, and these are the only ones that are stored in our hospital, and they are color coded. The blue or light blue Venturi is 24%. So if you use this, you're targeting 24% oxygen delivery to the patient. The white one is 28%. Yellow 35%, red 40%, and green 60%. If you look carefully at the rim of the Venturi, you will see that it identifies the potential FiO2 and instructs you as to the fresh gas flow required to achieve that concentration. In this case, we have 40% oxygen requiring 10 liters of flow. And each one of the Venturis will have this. The one on the left there is 35% oxygen requiring 6 liters of flow, and the green one is 60% oxygen requiring 15 liters of flow. If you look carefully at the top of these devices, they all kind of look similar, don't they? But they're not. And if you turn the device over and look at the inside, you'll see that there is a difference that may not be easily apparent. Let's start looking at the red one there, the 40%, and I'm just going to put a little arrow on here. This is the injector port for this device, and you can see that you can look all the way through it. It's a pretty big hole. Compare that with the 24% device, the blue one, and it's barely a pinprick. It's really, really small. And that's because that's how it's designed. The smaller the hole, the lower the flow, the greater the Venturi effect. And you can see that that hole gets a little bit bigger on the white, 28%, bigger again on the 35%, but the 40% is fairly enormous in comparison. This is a 60% oxygen Venturi device. It's demarcated by its green color, the narrow slits on the side, and the labeling that states that you give 15 liters to achieve 60% oxygen. And let's discuss how a Venturi device works. In this cartoon, we have oxygen tubing connected to a flow meter that's running at 15 liters per minute. The tubing connects to the barrel of the device, and inside the barrel there is a narrowing at the injector site. Now beyond that point, it widens up again, and the body of the device contains 2 or more, maybe 4 air entrainment ports. So they're the air entrainment ports, and the oxygen mixture between oxygen and air then travels into the face mask. So that's the direction of flow of oxygen and air into the face mask. The face mask itself contains exhalation ports. Gas flows from the oxygen tubing into the narrow part of the venturi. Once it reaches the injector port, it accelerates, generating a suction effect, entraining air into the wider part of the venturi and then into the face mask. The narrower the injector port, for example, 24% oxygen, the greater the level of air entrainment. During inspiration, fresh gas flows from the oxygen source into the venturi and air is entrained. The entrainment ratio is determined by the gas flow and the size of the injector port. A 24% oxygen venturi has an oxygen to air entrainment ratio of 25:1. That means that an oxygen flow rate of 2 liters per minute results in a total flow of 25 times 2 or 50 liters. This in most cases will exceed peak inspiratory flow. Now, going back to that paper from Anesthesia in 2007, you can see here that on the left-hand side for 300 ml tidal volumes with a respiratory rate of 10, 20 or 30 breaths per minute, the devices perform really well. And it's also true with the 500 ml tidal volumes. So you can be pretty happy that if you're using Venturi masks, your Venturi mask across the board for respiratory rate and for tidal volume performs pretty darn well. And I put these on and I try them out to see, it looks like a magical number, but they really are quite robust in normal breathing patterns with a little bit of tachypnea, with slightly larger tidal volumes. They do really well. So they are tremendous devices and they're very, very effective for patients with moderate levels of hypoxemia. Where there's severe respiratory distress, you are gone. These will not work because of that big problem with the air entrainment ratio for higher FiO2s. Remember also, of course, that in exhalation, the patient must exhale out the side ports of these devices. So you got to get the flow out of the side ports of these devices. But you don't have the same problem with Venturis as you have with simple face masks, because the overall flow is much higher with the Venturi when you look at the air entrainment ratio, even at low levels on the flow meter. As I said, 50 liters are going through with 2 liters on the flow meter, which means that the chances of the patient rebreathing carbon dioxide is extremely low in patients who have Venturi masks. So high gas flows prevent rebreathing and gas is vented through the exhalation ports. The performance is excellent. It's pretty well fixed for moderate respiratory distress and hypoxemia. The oxygen percentage is independent of the patient's respiratory pattern. It does struggle, the Venturi device does struggle with a higher FiO2 and a rapid respiratory rate, and there is no point even considering trying to find a Venturi for more than 60% oxygen. They don't exist, and they would be really problematic if they did. So in summary, Venturi masks are excellent devices for precise control of oxygen therapy at ward level. Modification of FiO2 requires a change in both the Venturi device and the flow rate. So that is a problem. With the other devices, you just had to turn up and down the flow. But if you wanted to change things, you got to find yourself the other next Venturi up. So if you're on 24%, you got to change it up to the white one, the 28%, etc. And there is a risk of error. For example, that somebody might put in a Venturi and turn on the wrong flow. And that does make it a little bit problematic. And they really are not as effective in severe respiratory distress. Now, if we look at the 3 different devices that we have discussed in this tutorial, we can plot the flow rate against the expected FiO2. So if you look at the nasal cannulae, and that was the first device that we looked at, and remember, it starts at 20 and there's 4% for every additional liter. With 5 liters of flow, the patient will get 40% oxygen. Now, if we use a CO2 face mask that measures, that's the simple face mask that measures end-tidal CO2. This is the one that we tend to use in our practice, and I have the little leaflet that comes with this tells us exactly what FiO2 to expect. So 6 liters of flow with a simple face mask delivers 40% oxygen, remembering that you can't give below 5 liters. And finally, with the Venturi mask, to get 40% oxygen, you have to give the patient 10 liters of flow. So that's quite remarkable. The difference as you go up with this, from nasal cannulae to standard face masks to Venturi masks, there's pretty amazing increase in the amount of flow that you need to give. And the reason why the Venturi requires a higher flow is twofold. The oxygen that enters the face mask has already been blended with air so that the volume of the face mask acts as a reservoir, and very, very little air is actually entrained due to the combined highish flow and the mask. Conversely, the simple face mask receives 100% oxygen, and that is blended within the mask and the oropharynx with air, some of which is entrained into the mask. It is, of course, possible to give 10 liters of flow into a face mask or nasal cannula, and potentially you can give 60% oxygen with 10 liters of flow in each of these situations, but that's not guaranteed, and of course it varies from patient to patient. So which device to choose? Well, in my view, if the patient is mildly hypoxemic and you want comfort, and particularly if you're using oxygen cylinders for transporting a patient in an ambulance or around the hospital, or if they're on long-term oxygen therapy, you really can't beat nasal cannulae. They're phenomenally effective, they're really efficient, and patients find them very comfortable. If you're looking for precision delivered FiO2 in moderate hypoxemia, then the Venturi is the best device to use. Where you have to adjust the flow or the FiO2 a lot, for example, if the patient is being sedated, well, a face mask that has an end-tidal CO2 connector on it is a great choice in this situation. And you might, for example, use this in the operating room with a patient who has received a spinal anesthetic, who's being sedated. This is a very simple approach to use where you can dial up and down the FiO2, and of course you may be physically present yourself to make sure that it's working. And really, if you've nothing else, you can just use a standard face mask. It's very important though, when you're looking for a face mask, to be careful about what you're picking out of the press. Now, these are 2 different face masks, and the one in the middle is, and they both have Venturis connected to them. The one in the middle is the correct face mask for the Venturi, and you can see in this that there are slits just above the side of the nose and on the side of the face. So there's these big holes in the face mask for letting air out. The second face mask is for a nebulizer, and you can see that, and the picture on the left shows this more correctly, that there aren't any holes there. There's this little bit of plastic that covers over the holes on the inside, and these are used for much higher flows. And if you put this mask onto your face, it almost smothers you. It's absolutely horrendous. So don't put these on to someone who's on a Venturi. They find it really hard to exhale. Let's revisit Trish and Jesse in the medical assessment unit. You remember Trish has community-acquired pneumonia and Jesse had a COPD flare. And we were told that Trish received 30% oxygen and Jesse 50%. And I did pose the question, how do you deliver 30 and 50% oxygen? And here's the strange rub of it. It's really difficult to give somebody 30% oxygen through the devices that we've already discussed. Unless you give 2.5 liters, for example, through a nasal cannula, really it's quite tricky. There isn't a specific Venturi that's provided that does 30%. And so it's much more likely that Trish was receiving oxygen through a high flow device that we'll discuss in a future tutorial. With respect to Jesse, for him to get 50% oxygen, it's likely that he received 8 liters through a face mask or indeed a high flow device. But it is quite astonishing how the standard devices that we have are not that precise. There isn't an easy way of giving either 30 or 50% oxygen to a patient. If you need a higher FiO2, you should consider in the short term a non-rebreather face mask, here modeled by me. And the key component of this is that bag that's sitting in front of my chest, and it's known as a reservoir bag. Now, you will be familiar with devices that look like these. You may have put them on patients, you may have seen them on TV, and certainly if you've ever been in an airplane when they're doing their demonstration, the flight attendants are demonstrating what happens in emergencies. They will say, well, if the cabin depressurizes, these masks will come out of the ceiling. Put them on yourself first before you put them on somebody else. Don't worry too much if the bag doesn't inflate. Well, you really should worry if the bag doesn't inflate, but you probably won't have time because you will die of hypoxemia. The whole purpose of the reservoir bag is to give you sufficient oxygen to stay alive. The components of this particular device are a fresh gas inlet here and an inspiratory one-way valve on the inside of the mask, and there are expiratory one-way valves on the side of the mask. Now, the non-rebreather face mask is connected to the oxygen flow meter on the wall, the standard flow meter that you see everywhere in the hospital and on oxygen cylinders, which makes it really portable and useful in emergency situations and on ambulances. And it's able to deliver a fairly high inspired oxygen tension, remembering that we ran into the problem of not being able to get beyond 60% with the Venturi, but also the issue with the very, very high flow needed for the Venturi. With the non-rebreather, 10 liters will deliver approximately 80% oxygen. So this is an amazingly efficient way of getting that amount of oxygen. This is roughly twice the amount of oxygen that you get with a Venturi device for the same flow rate. It is believed, although I'm not sure I believe it, that 15 liters will deliver between 90 and 100% oxygen. And the reason why it's able to do so is because the patient, what's happening is that there is flow going into the device continuously. So as throughout the minute you're dialing up 10 or 15 liters of flow, that flow is going in all the time. Patient only inspires for maybe 10, 15 seconds at most. So the rest of the minute you've got 10 liters per minute flowing past this inflow valve and into the bag, and the bag is filling. And then when the patient takes a breath, they take it through this one-way valve into their mouth and their nose. So the patient draws oxygen from two sources, from the fresh gas flow that's coming in at 10 liters per minute, but this is hugely augmented by the flow of oxygen coming from the bag. So the patient gets a much, much higher FiO2 than, for example, one would see from a simple face mask, but also because that valve is one way. When the patient exhales, the exhalation gases don't go back into the bag, they go out into the atmosphere. So non-rebreather face masks have a huge advantage that they are capable of delivering a high inspired oxygen concentration with modest inspiratory flows of 10 to 15 liters. And they're really useful for transporting patients with respiratory distress. And they're very, very efficient in the amount of oxygen that is required. But they have some significant disadvantages. First of all, performance deteriorates with increased respiratory rate and minute ventilation, as I've said, for all of these other devices. And they're frequently used inappropriately where a lower FiO2 is warranted. And that is hugely problematic, as I mentioned in the previous tutorial on hyperoxia, that if you give too much oxygen to some patients, they end up with acute hypercarbia and narcosis. And sometimes these are just slapped on patients for no particularly good reason, except that their saturation has fallen. And maybe a quick puff of oxygen is great, but you really need to have control over what you're giving. And it's really, really hard to titrate the FiO2 up and down with these devices. They're pretty much all or nothing. You turn up the flow to 10 or 15 liters and hope for the best. You really don't know what inspired oxygen tension the patient is getting. Let's review this tutorial. In the tutorial, I covered oxygen therapy. This was the first of 3 talks on this particular topic. We discussed the problem of peak flow and then moved on to a discussion about different devices. The variable performance devices, they are nasal cannulae and simple face masks. And then we looked at fixed performance devices, Venturi face masks and non-rebreather face masks. And I looked at the pros and cons of using all of these different devices. Next time, I will discuss the concept of entrainment ratios and how oxygen and air blend. I'm going to talk about how you can calculate the inspired oxygen concentration from oxygen and air flow, and how you can calculate flow rates from the desired FiO2. And finally, I'll just mention why I think high flow oxygen therapy is necessary before we move on to look at high flow devices and high flow systems. I'll see you then, and I guarantee you'll learn something. So that was part 1 on oxygen therapy. I hope you found it useful. Next time we'll look at high flow oxygen therapy and explain in more detail the concept of entrainment ratios. If you're enjoying these tutorials, don't forget to subscribe on YouTube or follow these tutorials on ccmtutorials.org. I'll see you next time, and I guarantee you'll learn something.